So good morning, everybody. My name is Thomas Kinney. We're conducting some continuing education refresher training for Travis County ESD1. We are recording, so watch your P's and Q's. Right now it's just me and Foster, so no big deal. Training is going to be twofold today, two lectures, one on trauma update and one on special patients. Each one will be about an hour and a half, so a little bit longer than we've been going, but we're trying to play some catch up because of some inclement weather there a couple weeks ago. Basically, we're going to be going for trauma update first. We're going to be going through some PHTLS stuff. I'm going to add some of my own little lifeisms about trauma and hopefully make this worthwhile for everybody. If you are watching it and you want to get CE, you need to contact me. Email is tkinney@tcesd1, and we can work out some arrangement to get you to watch the videos and get you the tests and whatnot. So there's two sections to this trauma module. First one is TBI, which is really long. The second one is trauma update summary, which is really short. I really wish it would be opposite. So I'm going to move through the PHTLS TBI one pretty quick and going to linger on the summary a bit more. I think it's more pertinent to things we do every day. Most of our head injuries are either really bad or really minor. And either way, they're a doctor's problem. We just need to keep them alive to get them to the hospital. That is not a PHTLS training. That is just a TKism. All right, I have these slides in kind of PDF format, so they're a little bit different. You can see the instructor notes this way. That keeps me from having to read everything. They're available on our classroom for the department, so feel free to have a look at those if you haven't already. To get CEs, you need to do the test and do an eval and email those to me. Foster, I already have some of your certs, so I'm going to try to email some of those out tomorrow so you guys can start entering for your recert. So TBI stands for traumatic brain injury. It's any time that you have an injury to your brain, as the name states. A few years back, all the millionaire football players were starting to show signs of TBI a lot in their retirement and older age. They started to make a pretty big deal about how we deal with TBI, and as such, it became pretty mainstream for EMS. And when we do standbys at football games for the high schools, and we deal with car crashes and motorcycle crashes. So traumatic brain injuries are important. With any injury, any traumatic injury, especially like major multi-trauma, there are multiple problems to worry about. The one thing that TBI is going to do, it's going to make your patients unresponsive, which means they can't manage their airway. So these people are really good candidates for RSI, airway management. Altered level of consciousness, confusion, repeated questioning. These are signs of traumatic brain injury. Severe unconsciousness with a hole in their head is a sign of a traumatic brain injury. We can use mechanism to help determine if we might have a TBI. We're moving away industry-wide about using mechanism on the injury or MOI as kind of the only factor. So we need other things. They fell 10 feet and they're altered and repeatedly asking you the same question. That's a sign of a TBI, but a 10-foot fall wouldn't necessarily meet trauma criteria in our area. So keep that in mind. And please also keep in mind that just because they don't meet trauma criteria, you can still go to a trauma center and bypass the local smaller hospital if you think that there might be a greater issue. You just need to document why you did it. And just because you think there might be a greater issue is a good reason. Biomechanics of a TBI, falls, strikes in the head, anything. It can be something minor like a hard stop in a vehicle, airbag deployment might hit them in the face. They can actually cause traumatic brain injury, the coup and counter coup and whatnot. We'll learn about those here in a little bit. So just some numbers. It affects a ton of people. It's one of the leading causes of injury in the world. And the U.S., of course, leads that charge. People riding motorcycles without helmets does not help. One person sustains a TBI every 21 seconds. That's a lot of people. So most common causes of head injury, motor vehicle crashes is number one. And just when they're in a motor vehicle crash, it doesn't necessarily mean they hit their head. They can have a sudden stop, can cause that the brain to move forward in the body, the whole secondary movement, coup, counter coup injuries. You can have direct injuries from sports, from falls, from violence, and then 10% are work or sports related down there. So anytime PHTLS is really big on the scenarios, so we're going to go through some of these, but anytime you get a call, you start your assessment with the call text. I would encourage you to not take that as set in stone. They do get it wrong, and they do have certain criteria they have to fit what they're getting into. So they might come across as one thing and be another. So don't get target locked that it is going to be trauma, only trauma, when there might be another cause, especially car wrecks. It does happen where people have diabetic problems or STEMIs and strokes while they're driving. Scenario, your dispatch report of a male who was riding a skate park, fell and hit his head. Scene is safe, 21-year-old patient. His friend tell you they were trying to see who could ride the longest down the rail when the patient fell. Patient struck his hand first, then his head on the concrete. Patient is not wearing a helmet. All right, so normally I would be asking questions here. I'm just going to go through it for simplicity's sake. Things you need to be worried about. Did he lose consciousness? He hit his hand first. That means he kind of protected his fall a little bit at least. Then, of course, there's your sample history. What medications does he take? If he happens to take a blood thinner, that really moves us closer to that whole trauma alert criteria pretty quickly. How high was the rail? All these things you're going to pick up pretty quickly. And how is he laying on the ground? Does it look like he landed and is still where he landed, or did he move? Did he get up and then go back down? And then, of course, our physical assessment. Is there bruising or bleeding? It does appear just by the picture you could see up here that the guy fell on concrete. That can be an important factor. Concrete's a lot harder than grass, if you didn't know. So injuries, he fell, hit his head, and I can tell you from experience that if they catch their fall with their hand, that can actually transfer some of the energy to their neck. When I was a really young corpsman back in the Navy, back in the antiquity, we had that where the guy fell, caught himself with a hand, and he had neck pain. So we put him in a collar and backboard just because that's what we did back then. Ended up having a C-spine fracture, no other injuries. Really interesting. I always thought that guy maybe was assaulted. Maybe one of his coworkers pushed him. But anyways, what injuries may the patient have? And so, of course, he hit his head. He might have a head injury, but he might have a neck injury. He could have a back injury. Is his hand and his wrist okay? That's a really common way to break a hand and a wrist. Go through your full assessment. Do your head to toe. A good assessment is your friend. Even if it isn't necessarily fully indicated, it is important. Anytime you have an external head injury, you also have that internal movement of the brain. So again, that coup, counter coup. Axonal injuries is actually when there's movement of the actual brain cells, the nerve cells move against each other, and they can actually tear. Diffuse axonal injury can be really dangerous and life-changing, if not life-threatening. Anytime you have a bruising on the outside, you might have bruising on the inside, so you end up with intracranial hematomas. Those can present a lot like a stroke, depending on where it's at and how it is. More of a hemorrhagic stroke, which essentially it is. And then it talks about the arm fracture a little bit. Concern yourself with that. We're going to have to address it. It might not be our highest priority, but if you have a full complement, an engine crew, and maybe a squad with you, you might have enough people to task somebody with the arm while everybody else is worrying about the head and the airway. Scene safety, lying prone, just your full assessment. PHTLS does the X, A, B, C, D, E. So X is extreme bleeding or life-threatening bleeding, airway, breathing, circulation. Then D has to do with mental status, and E is environmental concerns. Anytime we have trauma, we want to concern ourselves with the body, the patient temperature, because if you didn't know it, and low blood pressure, low body temperature leads to an improper coagulation of the blood, leading to more bleeding. That leads to more acidosis, which leads to more reduced clotting factor more, and that causes a coagulation cascade where their blood just cannot keep up with clotting, and they end up going into some pretty severe problems. And that's what we need to focus on in the field: prevent that downward spiral. So just going through the primary survey: oozing of dark blood from the right side of the head, open fracture of the distal right radius ulna, no active exsanguination. So that means he's not bleeding out extremely. The oozing of dark blood is probably normal for a head injury. No airway obstruction. Your partner is performing manual inline stabilization, so they're concerning themselves with C-spine. That's good. Breathing is at 20. It's still normal limits, and he's clear bilaterally, so nothing major there. His skin is pale, warm and dry though, which is good. If he starts to get that paleness, that means the body's starting to shunt away from the periphery, and the skin is going to show that in pale cool. So the pale is the beginning of that. If we go to start with the cool feel of the skin, then we need to start worrying about shock. Heart rate's 100, a little bit high for a young kid, but not that bad. And SpO2 is 92. EtCO2 at 32, so 92 is a bit low. I'd want that up at 94 at least. And EtCO2, I would consider that normal limits. Especially with him breathing at 20 times a minute, there's something wrong with his breathing here. The 92% and 20, so maybe he's a smoker and has some kind of lung problem. So GCS, right here, I like the way they list this. GCS of 13, eyes 3, verbal 4, and motor is 6. So it should be 4, 5, 6 for a total of 15. So that means he's responsive to verbal and some confused or inappropriate questioning. So it's always a good idea anytime we're talking about a GCS is that number is important. GCS of 14 or 15 or 13 or whatever, but giving them where the reductions are helps. If you start getting that motor reduction, doctors are going to be more concerned. 3 mil and equal bilaterally with sluggish response to light. So again, that's sluggish pupil or pupillary response is a sign of a head injury. Outside temp at 78. So keep in mind that you can go into hypothermia with an ambient temperature of 78 if you're put at rest enough. So anything under normal body temperature is actually considered cold. Anytime you have a multi-trauma, you should be sweating in the back of the ambulance, and they should be covered with a blanket. Open fracture, we need to concern ourselves with splinting and bandaging that, maybe stop some bleeding. So here are the red stuff. So because the outside temperature isn't particularly cold and the patient's skin temperature is normal, they go ahead and expose everything. That's pretty normal. Just keep in mind when you cut the clothes off, don't dispose of them. You want to keep the bottom clothes in place so the patient's laying on them, so you can fold the top clothes back on top and it's sort of a blanket. It's why it's important to keep blankets in the ambulance. If you need to get somebody trauma naked, then you need to be able to cover them and maintain that body heat. Once they start getting cold, they go into, again, that coagulation cascade where they stop clotting. That gets them colder, gets them more acidotic, which affects the coagulation cascade again, and they just spiral downward. And we need to stop that immediately. Once it starts, it's almost impossible to stop. All right, hemorrhage control. Foster, how important is that going to be?
100% number one, even before airway.
Right. So if there's major hemorrhage, we got to stop it. That's coming out of the military. The marches, massive hemorrhaging, airway, respirations, circulation, and head injury. Right. PHTLS teaches the X, A, B, C, D, E. Manage that controlled bleeding. So do your blood sweep. If you find severe hemorrhaging, throw that tourniquet on. Those days of a tourniquet stays in place until a doctor removes it are gone. We can throw it on there for now, finish our assessment, deal with that airway, then come back to that hemorrhage because we know that tourniquet has controlled that bleeding. We reevaluate it later, determine it's not that bad, and we remove it or loosen it. So is airway management for this guy probably not indicated? He seems to be maintaining his own airway. There is a problem with the SATs, so maybe we need to do a head tilt chin lift or a jaw thrust more appropriately. Maybe just some oxygen on top of everything is going to do because he is breathing at 20 times a minute. There's a lot of good arguments right now against backboards. We still have to be judicious, though. I would probably backboard this guy just because of the distracting injuries and the mechanism. Definitely he's getting a C-collar, though. And with the GCS reduced, I'm going to go with yes, he has a brain injury. right, so just some pathophysiology. A lot of different parts of the brain. If you're going to brain work all this, you can understand what the different parts do and help you determine where the injury is. Sometimes, if knowing that they got hit on the temporal side of the temple, you can help you determine what kind of their reaction is going to be to it. A lot of that, usually the brain injury is bad enough for pre-hospital care that if we're worrying about that, they're probably not that bad a shape if we're trying to figure out where the brain was injured. So they talk here a little bit about secondary impact syndrome. So again, you get hit, your brain moves and hits the other side of the skull. So the side you got hit on is bad, and the opposite side can actually be injured. It can make it more difficult determining exactly where the brain injury is. They have CTs at the hospital for that. Hypoxia leads to brain death. Brain death can represent itself very similar to a brain injury. Plus, when we have a brain injury, we have that swelling that can alter the circulation. Altered circulation means less oxygen, and that can affect mental status. So anytime somebody has anxiety, or they're combative, or they're angry, we assume they're hypoxic until proven otherwise. So we always give them that oxygen. We always try to manage their airway first to make sure that the problem isn't hypoxia. Now, we might deal with the hypoxia, put them on that non-rebreather, get their sats up to 100%, and they might still be combative, and that might just be a head injury. But we've got to rule out that hypoxia because that's easy to do, and it moves us in the proper direction of our patient care. So if we have severe trauma, hypotension can be a problem. The brain needs a lot of blood. If hypotension, the blood pressure drops, the brain might not get perfused. If we get down into the 70s, we're starting to worry about the brain. If we get down into the 80s, we're starting to worry about the kidneys. We still do permissive hypertension in the 90s, though there are plenty of studies and books out now saying that the 90s might be too low, that we should maybe be in the low hundreds to 110s. So I just said all this. It's almost like I've seen these slides before. All right, so if the patient's blood pressure decreases, the cerebral perfusion pressure will decrease. This causes blood vessels in the brain to dilate. This allows more blood into the confined space of the skull. This leads to an increase in intracranial pressure. Okay, so another reason to prevent that low blood pressure. As the blood pressure drops, the body's physiology is going to take over and allow more blood into the brain to perfuse it, causing more inflammation, which is going to add to the problem. The injury is perverting the body's ability to manage itself, and that's where we have to intervene. Eye puppers. Permissive, what am I thinking about here? Messing with our ETCO2, increasing number of breaths to decrease the amount of ETCO2. We don't do that anymore. We don't hyperventilate people at all. We can use the capnography, the waveform capnography, to guide our breathing maybe a little bit higher into normal or a little bit lower into normal, but we don't go beyond normal. We do hyperoxygenate by doing that, and we can put the capnography a little bit high into normal, low into normal as we see fit. So airway management, again, blood circulation, because the brain is injured and the body is injured, might not work as well for circulation. So that means blood flow or oxygen flow is going to be affected. So adding oxygen to this situation is important, and that means airway management is important. Now, that doesn't mean that we have to RSI everybody with a concussion. Oxygen, nasal cannula, non-rebreather, and escalate as we need. RSI medications, a lot of people talk about ketamine and how ketamine isn't indicated for brain injury. That's been kind of disproven. We can still use ketamine. And keep in mind that pretty much anything but ketamine is going to drop their blood pressure. And a drop in blood pressure is going to lead to increased intracranial pressure, which we want to avoid. If we think we're going to lose the airway, as soon as we start feeling that way about an unconscious traumatic brain injury, we have 4 minutes to intervene. Not 6, we have 4. They need to be intubated and oxygenated within 4 minutes. There are some interesting studies, and we might get to some of the numbers here in a little bit, but something like any trauma, any oxygen saturation below 94, it doubles mortality. So if it happens once, they're twice as likely to die. If it happens twice, they're quarter of the chance that they're going to survive, right? So it reduces pretty quickly. So we need to keep those sats above 94. So for me, for trauma is one of those situations where giving too much oxygen is probably never going to be bad. So I might start with an unrebreather, get their sats up to 100, and then I might, as I have more time, reevaluate and drop them down to nasal cannula. That's me. Pete's TLS does talk about doing the cannula first in this scenario. So use your protocols. If they're really sick, though, give them the non-rebreather, get their sats way up, and then reevaluate later about bringing them back down to normal. It is not normal for a normal human being to be at 100% oxygen saturation. Most of us are 97, 98. So this just goes through some anatomy. You can see the dura mater. My eyes are going. Periosteal layer, meningeal layer, arachnoid matter, blood vessels, subdural, subarachnoid spaces, and all these. These are ways that we can determine where the bleed is at. And where the bleed is at can determine how quickly they're going to deteriorate. Very, very difficult in the field. Assume anybody that is either unconscious or severely altered from a head injury has a severe head injury and take it very, very seriously. They're going to deteriorate and they need to be in the hospital as quickly as possible. Minutes are brain matter, okay? So that might mean in our area that we need to put somebody on a helicopter to save that 10 minutes. I am, of course, as most of you know, a big advocate of helicopter medical flights. Cerebral perfusion pressure, again, pretty difficult to calculate in the field because we don't have access to what their intracranial pressure is. We will use a mean arterial pressure. If you don't know what that is, diastolic twice plus systolic once divided by 3. Most modern monitors will show it to you unless your command staff has decided to take it away from you, so you have to calculate it. Use that mean arterial pressure. Anything over 110, you're getting into trouble range. Anything under 65, you're getting into trouble range. But you need to try to keep their MAT between 65 and 100 if you can. Keep in mind with the brain and brain intracranial pressure, sudden changes can be just as bad. So anytime we're going to use medication to reduce blood pressure, keep in mind the blood pressure and the intracranial pressure kind of go together. If you drop that blood pressure too quickly, you might negatively affect intracranial pressure. As we learned earlier, that might actually cause that ICP to go up, as opposed to, it might initially go up and cause a problem, then start to drop to follow the blood pressure. All right, so I've kind of mentioned this. The initial blood oxygen level, I would go with a non-rebreather. I'd probably end up escalating or dropping down to a nasal cannula on the way. The slides do recommend nasal cannula, and that's fine. One thing the nasal cannula will do for you, it will make your assessment and your discussion with this patient a little bit easier. It's hard to understand people in a non-rebreather mask, even though we're all getting pretty proficient at that. And again, spinal motion restriction, different people are getting different protocols. I would put this guy on a backboard. If I'm out in Llano, Texas, and I have to drive in for 2 hours, I might reconsider that. But, we're pretty close to hospitals. We're going to get there in about 20 minutes. Keep in mind that 20 minutes isn't enough for a backboard, so you need to make sure you tell the hospital, hey, they're on a backboard, and that means that they'll have people there to try to get them off immediately. They can do imagery before they do so. Primary brain injuries. This is a pretty bad bleed. Primary brain injuries, concussion, brain contusion, intracranial hemorrhage, cerebral laceration, and diffuse axonal injury. Epidural, subdermal, subarachnoid, intracerebral bleeding, those we see in the field a lot more commonly with strokes, or that old guy or lady that fell 3 days ago, 4 days ago, when they didn't think it was a big deal, but they don't realize that med they take is a blood thinner, and so slowly over time they got worse and worse until we get involved. This is a normal thing that happens. We deal with it. These need to go to a trauma center, and the main reason they need a trauma center is because trauma centers have a neurosurgeon available. They don't have to be transferred from that hospital to another place. And for Travis County ESD1, I'm shading heavily towards all of our trauma not going to Cedar Park. There's been some issues there. It's not that we've been getting it wrong, but they don't like it. And if they don't like it, they give us a hard time. And just to avoid that, I would bypass for any trauma with the slightest suspicion that it might be bad, go to a trauma center. And one of the reasons is Cedar Park is just because we do a trauma alert or don't do a trauma alert doesn't mean the hospital isn't going to have to do a trauma activation. And if we show up with a non-trauma alert because it doesn't meet the criteria, they do their assessment and determine that the patient has injuries, then they do a trauma activation and they have to transfer that patient out. So there's a cascade of events, and if we can avoid that, have them at the trauma facility when all that stuff is figured out, it will help the patient tremendously. And it's really only 15 or 20 minutes further down the road for us. So skull fracture, anytime you see damage to the skull, there's going to be damage to the brain. Those go hand in hand. It takes a lot of force to do that. So not only are you going to have the fragmentation, but you're going to have the bruising. One advantage of brain fractures or open skull injuries is that it actually has a place for the pressure to go. So cerebral contusion, that's a bruise of the brain. And again, I've said this several times. I'm just going to keep saying it. You might have the movement of the brain inside the skull, and it might hit one side then the other. That counter-coup injury might cause a cerebral contusion. You might not see evidence of that on the outside. Big one of those that we hear about is shaken baby syndrome. They don't have outward signs of a head injury, but they do have a severe brain problem, brain injury. One of the things that happens when we have intracranial pressure increases is it puts pressure on the base of the skull, base of the brain stem, if you will. And that brain stem is where the breathing regulators are for the body. And if they get pressure put on them, it can affect breathing. And we've heard apneustic breathing and Cheyne Stokes and these irregular breathing patterns. And that's what causes that pressure on that brain stem. I'm out of water. All right, so symptoms of concussion. If you've never had one, they're super fun. Vacant stare, delayed verbal or motor response, confusion and inability to focus, disorientation, so they might not even know where they're at or who they are. They can have slurred speech. Coordination can be affected. The more of these that you start piling on as symptomology, you might consider that means that concussion is that much worse. If they just have a little bit of a vacant stare, that might be pretty normal after getting bonked in the head. But if you start seeing all of these symptoms showing up, you might want to maybe take it a bit more expeditious transport. So when we're dealing with family members or even friends in this particular case, they're going to want to answer questions. It's really important for you to hear the patient answer the question. That gives you more evidence to how they're doing. Is it slurred speech or do they have a speech impediment? Are they disoriented or are they just a little bit confused? There's a difference. A little bit confused is, well, I think it's Monday, as opposed to, oh, it's definitely January 1st, 1973. All right, that might be disorientation versus confusion. But hearing them answer those questions is super important. Nausea, vomiting, photophobia, sensitivity to light, all pretty bad signs of a pretty bad concussion. If I get into the nausea, vomiting, dizziness, photophobia thing, I start really recommending transport, unless, like, I know they're going to be with a medical professional. Concussions do need to see a doctor. There is some evidence that CTs aren't as useful in determining a concussion. It is still effective, and it can rule out further bleeding or bruising of the brain. So different types of intracranial hematomas and brain bleeds. And the different epidural, subdural, intracranial has to do with which layer it's between. Intracerebral generally has more room to bleed. Subdural, same. Epidural has the least amount of room, which just means it's going to cause more pressure on the brain. All right, signs and symptoms of an epidural. You can see here how far it pushes. So one of the things that they look for in a CT is the line in the middle of the brain there. It's supposed to be dead center, and everything is supposed to be symmetrical on either side. So this is a brain shift, and that's generally a bad thing. There's supposed to be some vessels in here. You wouldn't see them with just a top view, but the CT will go through those and you'll see them. And they're supposed to be symmetrical on either side. And if they get squished or they're both smaller, that means that there's pressure in the brain. And that's bad. And keep in mind that elderly people, you do get brain mass deterioration with age. So they're more capable of surviving a brain injury. Subdural, you can see here, it's not quite as bad. Because there's not as much room for it to grow, it tamponades itself a little bit better and might actually help compress the bleed a little bit. You do still get pressure on the brain. You do still have midline shift. And the left hemisphere, that left vesicle was probably going to be compressed. All bad things, all lead to reduced outcomes. So you might see a dilated pupil on the side of the injury. Then weakness will be opposite, so the same with the stroke. Keep that in mind. All right, diffuse axonal, I can't say that apparently today, diffuse axonal injury. Widespread damage to the nerve axon. So the axons are the nerve cells. They interconnect with all the other nerve cells, and they have a certain distance between them, and they kind of have a homeostasis of how they like to be. When you get a diffuse axonal injury, that distance gets changed, either increased or reduced. They get moved and slighted. This is a severe brain injury. These people are in boats going 200 plus miles an hour that lose control. And I use that example because we had that guy. No way we thought he was ever going to live, and he had a diffuse axonal injury, led to us to believe that he was never going to make it, and the guy's still kicking. He has severe deficiencies in his functionality, but he's still alive. Almost always going to lose consciousness on this, and they might not get it back. It's a good idea to heavily sedate these people, intubate them, manage their airway for them, make them unconscious. Be wary of the drugs that you use. You might drop their blood pressure or raise their blood pressure. And I say that because Versed, fentanyl, both can drop your blood pressure. Morphine for sure too. And there was reports that ketamine could increase your intracranial pressure and this and that. And those have been disproven. The ketamine thing is not bad, and that's why it's kind of coming back in for that closed head injury drug of choice. Use your protocols though. Use your discretion. All right, so we're going to just progress through this. So it looks like nothing's changed that they're reporting. Possible injuries here. Obviously a brain contusion is on the list. A concussion, definitely. If there's going to be more of a brain bleed situation, that we're not probably going to see that. I don't see any need to dally on scene with this guy. We don't need to let him wait 24 hours to go to the hospital. Let's get him there. Let's get those CTs. Let's get him under observation. It's going to be the best thing for him. He might not want to go. Keep in mind, I don't recall what the age was, but skateboarders are often minors. Get the parents on a phone. Probably just with a fall off a skateboard, probably not going to get that diffuse axonal thing. I said it right 3 times in a row, and I got it wrong again. All right, again, I would just spinal motion restriction this guy. I'd put him on a backboard. If we have these soft backboards or something, that'd be great. But That's going to facilitate a reduction in movement when we go from our stretcher to the hospital stretcher. It'll help them a little bit if they decide to get the x-rays right away. Definitely going to give this guy oxygen. His sats were 92. We need to get those above 94. And again, I would probably start with an on-rebreather, reevaluate later if I can go down to a nasal cannula. I have bad luck with the downgrading. It seems like every time I try to do it, it doesn't work. I have to go back to an on-rebreather, but whatever. When you have time, you have time. So secondary survey, we haven't really got into this. This is where you're going to get your full head to toe. You're going to get more of your patient history, your sample history, look for your DCAT BTLS. Now, the secondary survey does not have to wait until you're in the ambulance. It doesn't have to wait for 10 or 20 or 15 minutes or 5 minutes. Now, if you have the personnel, you can do this all immediately. Your secondary survey, you're a little bit slower, so if you do a pretty rapid secondary, I would repeat it in the ambulance on the way to the hospital just to make sure you have found everything. You don't want to show up with that broken leg and not know there was a broken leg. Hospitals look at you funny. Somebody told me that once. Definitely wasn't me that did that. So I would just bet that the open fracture you would find in your primary, but pelvis is important to test. If you get these open book fractures of the pelvis, they can have severe bleeding and actually bleed to death. Abdomen, for a fall from skateboarding, I'm not really concerned about the abdomen, but I am going to touch it. I am going to listen to it. I'm going to look. You never know. And again, you don't want to show up having missed something obvious because you were lazy. That's never good. Anytime we have multi-trauma, these things have to be checked. Lungs clear bilaterally, no noted injury. So the way that you note an injury is that you put your hands on their chest and have them take a deep breath. Little small breaths to avoid the pain is not going to help you notice a flail segment. And if they're breathing small, shallow breaths, you might not hear the diminished lung sounds. Get them to breathe. It'll tell you a lot. Use your hands, use that feeling, because a lot of times the noise, fire engines running their diesel motors and extrication tools going and helicopters landing, you might not be able to hear crap anyways. So use your hands, get used to using your hands when you're evaluating the chest for injury. CSF is cerebral spinal fluid. If they have it coming out of their nose or ears, that's an implication that there's a skull fracture somewhere and that CSF is leaking out. That's bad. They used to teach this target test where you take a piece of gauze and you touch it to it, and the blood products and the CSF will move away from that spot different rates, and it helps you see a target on the gauze. I've actually done it to a known, like I knew that it was cerebral spinal fluid. I could tell by the way it looked, and it didn't do that. So I don't know what kind of gauze they were using back in the day, but it's still cool to try. Keep in mind raccoon signs where they have bruising around the eyes, battle signs where they have bruising behind the ears. These are bad signs, can imply skull fractures. They keep throwing this patient has fracture right ulna, like we're not supposed to forget about that. Hopefully by now you've got this bandaged and splinted. Position of comfort with good circulation back to the arm, good cap refill. And then we tuck it in and we don't worry about it again, hopefully. So our secondary survey is going to be our first good set of vitals. Again, you show up with an engine crew and a squad. You got 6 guys. A lot of this stuff is going to happen simultaneously. This set of vital signs, 101 temperature, so COVID risk. Everybody gown up. CO2 is a little bit high. And now his respirations are 10. Is this the same guy? And his blood pressure is high, so maybe we're getting some deterioration here. Heart rate's 56. That's, again, slow. So Cushing's triad tells us if they are getting intracranial pressure, you'll get an increase in blood pressure, a drop in heart rate, and irregular breathing. It's kind of hard to tell the irregular breathing, but SATs are 90 now, so this is a deterioration if this is the same guy. And GCS is 7. Guess what he just bought? So they did a good job here. They get deterioration of status. They check a blood sugar. It's 110. That's normal. And he's unconscious now. So it was pretty bad. So Foster, what are you doing for this guy now?
The BLS before ALS. So if he's not on high flow oxygen, do that. His rate of 10 is a little slow. I would try to bag him to the end tidal of like 35 to 40. Probably more 40, right around 40 be the target versus 45. And then, yeah, you're going to start 2 lines if you can, but at least one. You're going to have to sedate him, paralyze him, tube him.
Right. And, like Jeff said, um, I'm going to repeat what you said just because I don't know if your voice will come over the recording. Foster basically said start BLS before ALS. If you're not on high flow O2, get on high flow O2. Maybe we need to support his breathing because it's so low. So maybe a BVM and start giving him a little bit of extra breaths. Try to get his sats up, and probably going to get a large bore IV, sedate him, and probably going to end up intubating this guy. If you can, if you have good luck with an on-rebreather, getting a sats up, you might get in the ambulance before you do all that, just to protect the patient from all the prying eyes. So obviously this head injury is a bit worse. I'm kind of curious how high the rail was now. I actually ran in a motorcycle crash. The guy was going 35, avoided a dog, laid the bike down, and just tapped his head on the ground and died. So it doesn't take a lot. So pupils, keep in mind in this middle of the summer in Texas when you're outside, it's going to be so bright your light is going to be useless. Cover the eye and then release the eye and see if it expands. That's the same as capillary refill as shining a light in there. A bit more effective sometimes when there's a lot of light. It's a good idea if you think their eyes are not, or pupils aren't looking right, look at your partners. Like pinpoint pupils like you see here in C is pretty unnatural even for severely bright areas. A would be more normal, I would think. C is leading me more towards probably opiates. Maybe there's some drugs involved. If it's really bright out, keep in mind when it's bright, your pupils constrict to isolate, to limit the amount of light coming through. So if it's really bright out, he's laying on the ground and his pupils are huge, that might be actually a sign of that brain injury. It's easy when they're opposite, they're different. You can see down here in D where one's pinpoint, one's blown. It's easy to tell that maybe there's a difference and maybe there's a problem, assuming they don't have some genetic problem doing that for them. And with Jess's friends there, you might not be able to figure that out. But with everything else going on, Cushing's triad showing up with a reduction in heart rate, increase in blood pressure, respirations are jacked. I'm guessing there's intracranial pressure. So I'm guessing we're going to see some version of one of these that is abnormal. All right, so what's most likely happening to the brain cavity? Swelling. There's bleeding in there. What type of injury? A brain injury? Hello? It's probably the arm. All right, what type of injury could be causing? They say epidural hematoma, axonal injury caused by the patient striking his head, and a counter-coup type of injury causing the axons to shear. I don't know everything, but my understanding is axonal injury takes a lot of force. And I would be really surprised if that's what this was. So I'm leaning towards epidural hematoma, but as paramedics, it's always better for us to have a differential. The 2 or 3 things we think it could be, and we start ruling them out. Are we going to be able to rule these out in the field? Probably not. But we can see that there's maybe an open temporal fracture, and that might lead us to epidural hematoma. All right, so mass effect is the pressure in the brain is starting to affect the entire brain. It's starting to cause it all to squish, it's causing mass effect. I'm assuming that's what they mean. And that's why it's important to get these people to the hospital. They can actually do things to relieve the pressure to prevent actual increased brain injuries. So decorticate, core, their arms are going to be towards their core, decerebrate, arms are out. Alterations in ventilatory patterns, Cheyne-Stokes, apneustic, just abnormal breathing patterns. All of these are bad signs that there's a pretty bad brain injury. If you see somebody progress, they'll usually go to decorticate and then they'll go to decerebrate if they continue to progress with that brain bleed. The best thing we can do if we start getting to that point is speed, lots and lots of diesel. But again, anytime you have a brain injury and you see that bradycardia and hypertension, be thinking Cushing's triad. Cushing's triad is caused by ICP. All right, so they're saying hyperventilation. Again, we don't technically hyperventilate. We breathe at the high end or low end of normal to affect their ETCO2. As Foster said, we're going to push their ETCO up to 35, maybe up to 40, high end to normal, maybe up to. We're going to either way. We're going to try to stay a little bit lower. Wait a minute, Foster. Am I getting this wrong? For ICP, we want more acidosis, so we want it lower, right?
So for the intracranial, it depends. With the SATs that 90 he had, to me, you want to improve the SATs at least to 94. If that means bagging them to like an end tidal of 38 or 40,
right,
sounds good.
Right.
Otherwise, yeah, oxygen's a constrictor, right? So we don't want 100% SATs. We want to just bag them up to 94, and if that leaves their end tidal at 47, okay.
Right.
That'll lessen that bradycardia slightly. Like you say, we're buying seconds or minutes.
Right, like Foster's saying, we don't hyperventilate, we hyperoxygenate. So, like he's dead on, we give more oxygen to get their SATs up, but we don't need to get them up to 100. And if we did get them up to 100, we need to start correcting that. So, on the helicopter, when we have people on a vent, if they're really sick, we'll start at 100% FiO2, and we'll immediately, the first thing we'll do when we get them stable and get in stable flight is start dropping that. And we'll start dropping. We'll drop by 50. We'll drop down to 50 and see where it goes. And if it starts to drop, then we might come up a bit. But we're going to try to reduce that as quickly as we can down to room air if we can, and keep their SATs above 94. Keep in mind that if you are playing that game and you're trying to reduce that oxygen saturation, anytime you drop below 94, you're changing their mortality rate. Then that's statistics, but we use that to guide what we do. All right, mild hyperventilation, target of 30 to 35. So again, we're not going below normal. We're just keeping them at the low end of normal. So 20 breaths for a human or adult, 25 for children, and 30 for infants. I'm going to start moving through this. Secondary brain injury, hypotension, hypoxia, cerebral edema, and the ICP, intracranial infection, and then seizures. So those are things that are going to come secondary. Man, if we start getting those in the field, we're behind the 8 ball. We need to move. Treat your seizure like you would treat any seizure. Keep in mind that Versed might do stuff that is going to drop their blood pressure. I was talking to one of my flight nurses the other day, and she was saying that they use Versed all the time, and they hardly ever see a drop in blood pressure with it. My experience in the field is every time I give it, I see a drop, 10, 20 points, almost every time, without fail. And if they're already at 110 and you give them, then all of a sudden they're down to 90 and you're creating problems. So be careful. If you can low dose your Versed, do it. Follow your protocols though. The doctors know best. We need to find out if they take anticoagulants, so Coumadin, Plavix, a bunch of other ones on the market. Antiplatelets, aspirin would be the main one. If they take an aspirin a day, that just means that they're going to bleed a little bit more freely. They're not going to clot as effectively. All right, so prevention of secondary brain injury, keep them oxygenated, minimize movement, and get them to the hospital very quickly. All right, so he decreased, the GCS dropped again. For me, this guy's tubed already. He's unconscious, sedated. And hopefully we're doing that on the road with plenty of help with us. They chose a level 1 trauma center. Here up at ESD1, trauma or level 1 is, what a 45-minute drive. We have a level 2 that's about 20 minutes from a lot of our area, so we'll usually go to the level 2. And he did have an epidural hematoma. At least I got that right. Seems I got everything else wrong. So critical actions, life threats, limb threats, and then the rest. So if you don't have plenty of people, that severely open, broken fracture of the arm might not get dealt with as soon as we would like. So if you have any questions, just shoot me an email. we can have a discussion. Foster, you got any questions on this?
No, sir. I'm good. Thank you.
PHTLS update. I'm gonna summarize my version of PHTLS update. TXA and whole blood. All right, so anytime we have a multi-trauma, we need to do a rapid primary assessment. X, A, B, C, D, E. Marches is one of those military one. Massive hemorrhage, airway, respiration, circulation, and head trauma. The reason for that is that if they're going to bleed to death, continue to bleed to death, and we don't stop that, then we can't save them. We stop that bleeding, and a lot of times that severe bleeding can be fixed with something that's really quick to do. That can be either a tourniquet, some combat gauze, and direct pressure while you do the rest. Once we get done with that, we need to make sure they have an airway. If we have multiple personnel, we can have multiple things going on at once. You know, basically stopping the bleeding is a BLS skill, so have them do that. Giving the airway, you might want your advanced EMT while you're getting your drugs and your intubation equipment ready and doing your full assessment. We still teach the golden hour. We want to make sure we have them to the trauma center within an hour. And that has a lot to do with systemic inflammation that is going to be caused by the traumatic response. It has a lot to do with coagulation cascade, acidosis, body temperature. We need to get them to the hospital so the surgeons can fix the problem and start them on the recovery. Our area is rural enough that consider a helicopter, and that helicopter is going to do you more good the earlier you call it. We're lucky that Starflight comes out to our priority 1s and 2s auto launch. If for some reason they don't come, we might need to request another service. We have AirVac out of Marble Falls that can get here pretty quickly depending on where in our district we're at. Everything we do in the field helps reduce long-term disability, and that's why that golden hour is still important. If we can get the bleeding stopped, we can get the oxygen in, we can get some resuscitation going with fluids and TXA and maybe whole blood if we have it, that directly goes towards them getting out of the hospital. We might be able to get them to the hospital by doing nothing. That's true. We might be able to just get them in the BLS it the whole way and be heroes and get them there on time. But if we can do more in the field, we're going to give them a better outcome. Multi-trauma is not the situation where we want to decide to not do that now because I'm not sure they really need it. They need it. Do it. So this slide, golden principles, focus on principles rather than preferences. A principle is the goal. Things that you need to get done for the patient. The preferences are kind of the way you would prefer to do it. And those can change. Then the reason we focus on principles is the preferences can change. So the principle is the same. Stop the bleeding, refill the tank, and get them oxygen, right? So the principle is to do that. How we do that is the preference. Mechanism of injury can be very important. We're not using it solely for trauma alerts much anymore. But if it is a severe mechanism of injury, use your discretion to call that trauma alert. If there's any trauma alert with blood thinners, they don't go to a normal hospital. They go to a level 2 or higher trauma center. No matter how minor that fall was, they go to a trauma center. And we can go to a trauma center and bypass a non-trauma center without calling a quote-unquote trauma alert. And that's, again, provider discretion. But if you have a local hospital, it's a level 4 trauma center that is showing or demonstrating repeatedly that they're not interested in trauma, and you think that it might be questionable or might lead to a pretty bad injury, you might want to just skip them and go to the trauma center. Just justify it in your report that you felt the patient had severe enough injuries to require a trauma center and go. Also, I just want to reiterate for our ESD guys that a trauma alert is what we do in the field. A trauma activation is what the hospital does. They might do a trauma activation based on our alert, but they also you might show up with a 12-hour-old injury to a regular level 4 trauma center, and they might find some injuries that they think needs to be trauma alerted, and that means that patient's getting transferred. So again, if we use discretion before that and get them directly there just because it might be bad, we might save a step, and that's always in the patient's best interest. So primary survey, exsanguination, that's what the X is for, exsanguination. That severe bleeding, airway, breathing, circulation, disability, exposed environment. Disability being mental deterioration, generally speaking. So any deterioration and disability with a significant mechanism of injury requires a trauma center. And any deterioration in mental acuity is hypoxia until proven otherwise. These are some TK-isms that I have learned over my life. Traumatic airways can be bad. They are a lot bloodier, a lot more saliva, a lot more food products. Be ready. You've probably all heard the salad method or the whatever they're calling it these days. You have your suction ready, and you can lead with your suction. Put the suction in. We have the decantus. They're a lot bigger orifice. Stick the decantu in there, get that suction out, and then when you go in, it'll be nice and pretty, and you can just pull that suction at the last second. It'll help you tremendously in these difficult airways. Not all airways are pretty, and those are the ones that usually need that intubation versus the iGel or King LT. Yeah. All right, so your secondary survey is going to help you determine need for specialized care. So again, pediatrics, geriatrics, special populations, pregnant people, we might need to change our decision based on that. Any multi-trauma that's pregnant, they go to a trauma center, and you work them all the way there if you have to because of the baby, and that is state law in Texas. There is a recent incident with somebody that I actually know where that happened. The medics did a good job of resuscitating GSW to the head because she was pregnant, and the baby is alive and appears to be viable. So that 0.1% is what we work for. So pre-hospital, our role pre-hospital for trauma is to prevent death and prevent disability. Prevent death is easy. That's what we do. Keep them breathing, keep the blood moving. We can do CPR and keep them from quote-unquote death. But the bonus, the thing that we do when we get better and better and we're on our game is we decrease the disabilities long term. And we can do that by good resuscitation techniques, stopping the bleeding, oxygen, and TXA, which helps reduce the clotting. I'll go over TXA here in a little bit before we get too far, before we finish up, which we're almost done anyways. NAEMT offers a lot of courses. They cost money. People are proud of them these days. All right, so TXA, I'm going to go into that a little bit. Then I'm going to go into blood and why whole blood is better than products and why products are better than no blood. So TXA, tranexamic acid, it actually, the way the body works is you start to clot. As you start to clot, the body sends out fibrin. That fibrin starts to reduce those clots, and that's part of the healing process. The problem is when you have severe bleeding or severe damage, a lot of that fibrin goes out too quickly because it's responding to the amount of prostaglandin, right? So a lot of prostaglandin from the injury, a lot of fibrin comes out. TXA inhibits that fibrin from cutting up the clots, so the clots stay in place better for longer. So we give TXA early. Keep in mind, we give the first gram over 10 minutes. I would even target 15 minutes. And the reason for that is that if we give it too quickly, the body just processes it out and you pee it out and it does no good. And it can cause some problems in your kidneys if that happens too, which is a bonus for a trauma patient. So blood products, whole blood is the golden standard right now. It's becoming more and more popular in the field. I doubt we'll ever see it at ESD1. But I'm surprised like somebody like Austin Travis County doesn't have it. Early administration of whole blood is shown to get great results. It not only volumizes, but it adds oxygen carrying capacity and it adds clotting capacity. It does all these things. A long time ago, they figured out that they can spin the blood down and make blood products, packed red blood cells, what are they? I just drew a blank.
You have RBCs, fresh frozen plasma, FFP.
Right. So, and they learned that you can
Give
give
more
one
than
to one.
4, you need to give calcium citrate.
Right. And so you can give 1 to 1 of those, and they say that's as effective as whole blood. The trick is that the whole blood works best. All of the combination of the others works well, but not as good as whole blood. And the reason is because they got to put stuff in the blood to preserve it.
I think Hextend is one of the ones you're thinking about from way back. That
Oh
was the
yeah.
volume expander in the military.
Right. Right. So Hextend and those volume expanders were in the military for a pretty brief period of time. Um, they increased the volume, but they didn't increase oxygen carrying capacity. They didn't actually increase clotting per se, but they did definitely raise blood pressures, which affected clotting. So they didn't stay around very long. In fact, while I was in Afghanistan is when they went away. TXA is a better solution. It just uses the body's systems to its benefit. Mass transfusion in the field, we consider that 3 units of blood in an hour. If you have 3 units of blood in the field, you're doing some crazy good stuff. AirEvac just got authorized to carry 2 units. It's very rare that we'll give 2 to 1 patient. There are things to worry about, like the calcium that they put in it. I'm drawing another blank.
You give calcium citrate if it's 4 or more units in the ER at least.
Right. So all it can add to acidosis. So the hospital is going to deal with that. In the field, we're not going to worry about it. We're going to give the blood. We are going to maintain permissive hypotension. So we're going to give the blood, but we're going to try to keep them between 90 and 100, maybe 90 and 110 if we're feeling squirrely. So we don't want to give it too fast because we can cause more problems, and that is a thing that we deal with in the field. The combination of the two, you'll see amazing changes in the patient, and it might not cause them to come out of the hospital, but it would definitely give them the best chance they have. That I went through that a lot quicker than I thought. Foster, you got any more input on all that?
No, sir.
All right, let's take a 10-minute break, and we'll come back with special patients.
TXA, keep them warm. Stats above 94.
Oh yeah, yeah. Keep them warm. So again, if they get cold, the clotting cascade, cold blood doesn't clot. So if they get cold, that's bad. So keep them very, very warm. Again, you should be hot, and they should have a blanket on. All right. Thanks, Jeff.